Good morning, everyone. Welcome to today's webinar. Very exciting topic today. Considerations when implementing smartphones in hospitals. So I'd like you all to join me in welcoming our guest panelists today. Adrian Hutchinson, Chief Nursing Information Officer of the Royal Children's Hospital. Neil Cook, Network Team Lead of Royal Women's Hospital, and Patrick Premnath, Systems Administrator for ACT Health. And I'm Alan Stocker. I'm the Manager of Connected Health here at Wavelink. Before we get started, gentlemen, hope you're all keeping safe and well. Can I ask all of you just to give a quick introduction on yourselves and your organization, and Adrian, starting with yourself.
Thank you, Alan. Yes, keeping very safe. I'm Adrian Hutchinson. I'm a nurse at the Children's Hospital. I'm the Chief Nursing Information Officer and heavily involved in our EMR implementation for a number of years, and also across the Parkville precinct. The current job that I've been doing over the last couple of years has been implementing a unified communications project where we're rolling out smart devices across the hospital, about 850 devices across the hospital, and using that for all clinical communication as well as clinical documentation in a large number of areas. So we're just moving towards the end and wrapping up that project, and it's have had a few issues, mainly network related, but it's proving very successful in a number of areas.
And Patrick, if I could ask yourself to give an intro. Thanks for that, by the way, Adrian.
Hi, my name is Patrick. I work in the critical systems team at Canberra Hospital. We look after all the health facilities, government health facilities in Canberra. Working with the project team to actually implement about 2,400 clinical work devices with SOTI and Imprimatur. So I'm one of the teams that look after it, and I look after the physical handset part of the system and the MDM solution.
Thank you, Patrick. Neil.
Yep, my name's Neil Cook. I work at the Royal Women's Hospital. I'm the network team lead here at the hospital, and we look after all network and telecommunications, also support all the SpectraLink devices and the MDM here. So,
Thank you, Neil. So just for all of our attendees, feel free to fire off questions throughout the session. And we can have a bit of a Q&A towards the end of today's session. I'm sure our panelists will be keen to answer any questions. All right, gentlemen, let's get into today's discussion. You all work for organisations that have invested in purpose-built smartphone technology for healthcare. And Adrian, if I could perhaps start with yourself on the first topic, because I know it's especially relevant for you as working with you for the last 2 years. But the pre-purchase phase, how did you define the hospital's needs when it came to smartphone technology?
So we looked at, we pretty well trialled most of the devices and looked for their, well, if we take it back a step and see what is required from a clinical point of view for the type of device that you need. You need something that's absolutely hard to destroy. It's got to be droppable, it's got to be washable, it's got to maintain infection control standards. So they really guided what we would might use. We have a number of clinical applications that had to be compatible with and our clinical applications support both Android and iOS, so that wasn't going to be a problem. But when we went looking at devices across the market, there were only really a couple that could fulfill those requirements in terms of their IP rating. Supporting the applications, we're on an updated version of automatic updates of operating system, and was a big enough screen for staff to be able to view the clinical applications that they need. In some of our clinical applications, for instance, we can look at x-rays on some of our clinical applications, and we needed a screen that was big enough, and there wasn't too many devices that were going to fit the bill for that sort of thing. So that were really the considerations that we had. And we also ran a proof of concept in one of our wards, the Koala ward, which is a cardiac step-down unit. And predominantly we were looking at nurses' response to it, because they will be interacting with the device mostly. And, you know, we got overwhelming support on that proof of concept for the use of the devices that we chose.
Thanks, Adrian. Yeah, interesting with regards to the proof of concept, because I remember the setting up with you there on the Koala ward, and the reaction that we had from the nurses. So Neil, your experience was a little bit different. You'd heard that this was deployed, I think, across the road at your sister hospital, the Royal Melbourne, and they offered to lend you some of their devices. Can you tell me about what your trial experience was, and some of the use cases that you evaluated and tested?
Yeah, so we actually had a different platform in place at the start of the EMR project, and we're having a few issues with that particular device. So we lent some of the Spectra links from our neighbour Royal Melbourne Health, and instantly they worked, where we had numerous wireless issues with the other devices we were running. We trialled them for approximately, I'd say about a month, without any problems. We were only running one application on that device, which was our EMR Epic Rover application, and no issues at all. After that, we went out and procured a bunch of these devices to replace the other devices that we're using.
Yep. Thanks for that, Neil. Patrick, ACT Health's initiative, which I can remember now, sort of started well over 3.5 years ago, but it was around device consolidation and just trying to ditch the utility belt of devices, pagers, deck phones, Wi-Fi phones, duress badges. From an ACT health perspective, how has that gone, that transition from multiple devices down to that single smart device?
Yep. So from an ACT Health perspective, we've had traditionally pages across the hospital for all in emergency messaging and direct messaging for doctors. We've had wireless duress devices and deck duress devices. So we were actually looking for a consolidated a phone that would actually support all of that. So we looked for a phone primarily that could do a smartphone that could host an application, but also have the functionality to initiate duress calls, because that was a major part for us. Mental health and other areas that request duress, we didn't want to give them a separate solution to confuse them, which meant that we would have 2 devices on each belt. We wanted to reduce it down to 1. So that was our big driving force. And when we looked at when the project team went through and looked through the Spectra links, they noticed that obviously had the capabilities in there, and obviously the duress function, which was a major driver for us. So that was one of the big things for us. Currently, we have security guards with TRN radios and their mobile phones, and their work phones, a pager or 2. And we're working on with them right now to actually reduce that to just 2 devices, obviously the TRN radios and the clinical work devices that we are implementing at the moment. We've also rolled out the devices for duress as a trial, just to see how well they work, and they've been very good for us. So we are also looking at integrating all the clinical function into the duress application, and in the long term, looking at the reverse of implementing duress into the clinical application handsets. So in the end, we will have a single device. So it's been very good for us. So far, the feedback's been very good.
Thanks, Patrick. And yeah, interesting there about duress being one of the key requirements still. I'm seeing that as I work with hospitals across the country, that you know, as we're introducing new functionality such as mobile access to EMR, clinical messaging, paging as an app rather than a device, but duress is still very much at the forefront. And that kind of leads me on to the next topic, because you know having duress on the devices as well as all of these critical applications, one of the most important aspects then becomes the operating environment that the handsets are going on to. Obviously, the devices, it's like a train running on a track. It's only as good as the infrastructure that it's on. Maybe Adrian, just starting with you on this one, can you tell me about the path you've been on in terms of network considerations? How have you ensured voice grade Wi-Fi, and have you had any issues running 850 devices, smart devices on the network, and if so, how have you overcome those?
I'll preface that, Alan, by saying that we are soon to implement a new Wi-Fi network. So we've been in this hospital since 2011, and so the network we know has been sort of not quite up to scratch for a number of years, but mainly due to the fact that we've got such an increased use of wireless devices across the hospital, both from a staff perspective and also a public perspective. So we went out looking for a new Wi-Fi system earlier on this year, and I believe it's soon to be decided with a view to implementing next year. So that's the first thing I'd say. Yeah, we did have wireless issues, and I think that was a combination of understanding the devices and the infrastructure that was required to run them on, and also a little bit of experimenting with the different settings. Previously, we had devices that ran on the 2.4 gigahertz bandwidth, and we configured the spectral links when we had them on our system at the auto level, so they could fluctuate between 2.4 and 5. And we now realise that was probably not the right thing to do. And in recent months, we've moved just to purely 5 gigahertz, and connectivity issues have gone away. Having said that, we still do have some issues with our aging network, because occasionally WAPs go out, and we have connectivity issues in those areas where the WAPs have gone out. But where you're under a WAP that works, you're on the 5 gigahertz bandwidth, you've got a device, no problem at all. We can use all of our clinical applications successfully. One thing that we're very envious of Patrick on is the duress functionality, which again, once we put in our new Wi-Fi network, we'll be looking at deploying something. That was one of the attractions of the spectral links, that they have a duress button that can integrate with applications, and that will be a bonus for our hospital as well, to be able to move all clinicians to a single device. Previously, people would carry up to 4 devices on their clinical shift, and the project was always implemented with a view to moving to a single device for all communication, documentation, navigation, and duress. Yeah, so if any out in the audience are thinking of going down the line, follow the recommendations of the vendor, go with 5 gigahertz, and just make sure that your network assessment is appropriate prior to implementation. I think that would be the lessons learned from us.
Thanks, Adrian. And yeah, remembering the utility belt and multiple devices. I remember when you took me to the Koala ward to meet the nun, and I was astonished by the number of devices carried in order to get through the day. So I'm glad we've been able to help somewhat there. Neil, was it a seamless transition for yourself? I mean, your use case is a little bit lighter. You're not running voice quite yet. Was it a case of just putting the devices on the network and up they went, or did you have to make some considerations in order to adopt these devices?
Yeah, so most of our wireless devices that we were running beforehand, they were actually all decked phones, and it's been taken care of by our facilities maintenance team to look after the complete DECT system. So in 2019, we did a complete network upgrade and put in a brand new wireless network. So this was a first getting IP telephony working. And we've started off just with the Epic application on these devices, but we're soon to move into the voice, IP voice sort of realm. We've done some testing on the SpectraLink devices and we've found no issues. In saying that, we've also had a third party come in and do a test of our wireless, a full scan. There were a bunch of recommendations that came out of that as well, which was almost reprogramming each access point. So roaming zones worked, so the handoff for voice works better. We've put those recommendations in and we're going to get a post-test done as well. But due to COVID and other restrictions around roaming around the hospital, we've had to postpone that. But hopefully we can pick that up soon and get that done. And that's something definitely that we want to do before putting the telephony side out there.
Yeah. I mean, and that's really the important consideration is running voice across the Wi-Fi network. And Adrian, I remember back when we were having issues, we helped you out by spinning up that AMI advanced server that really took your Wi-Fi network and turned all 850 versities into sniffers on the network and helped you identify those issues, especially around the 2.4 and the 5 gigs and you know, looking at any coverage gaps and so on.
Yeah, you're right, Alan. The SpectraLinks are now the canary in the coal mine, and I must say the AMI advanced monitoring has been, you know, just gives us visibility over what's happening across the whole hospital. In fact, this morning, you know, we're able to dial into the monitoring system and look at, you know, we had a couple of reports of dropouts over the weekend, and we're able to dial in, look at the access points that were where the calls were dropping out, and we'll get IT to review that and then do some configuration. And just as Neil alluded to previously, you know, COVID has been a little bit tricky in getting people on site to do site assessments, etc. And we chose to roll out our SpectraLinks during the height of the pandemic last year and the lockdowns last year. So that created some problems for us. But I think, you know, over the last 12 months, we've come to terms with managing in a COVID environment and also understanding our network better. And with the monitoring tools, it gives us great visibility over what's happening and the ability to respond where needed.
Yeah, absolutely. And yeah, we've been doing a lot of those rollouts in the pandemic and remote staging, and it's definitely been deployment lessons learned on our side. Patrick, if I could ask you a little bit about the importance of ensuring interoperability. I mean, ACT Health, you've got a whole host of different systems there that need to be interconnected with, you know, multiple nurse call systems, alarms, MIEs, introduction of the Epic EMR. Can you talk to me a little bit around the considerations that you've made in terms of when you looked at the smart devices and how they're integrated into those existing systems today, some new, some legacy?
So ACT Health has a lot of legacy nurse call systems and a few new nurse call systems, but we are centralizing the nurse call systems now. We also have two direct systems, a security system, and several fire panels that we integrate all through the messaging integration engine. And this is just the non-clinical systems. From the clinical systems, we obviously have our EMR, we have all the other endpoints as well, which is another MIE all to itself. So when we actually chose the handset, we were actually looking for a platform, as Adrian mentioned before, that was easy to read, had a large screen, and also integrated with the existing systems very well. So the biggest challenge for us was integrating nurse call, which from a non-clinical perspective is how we have the most of. And we've been working to modernize it and look for a central messaging application. So we're working on that at the moment to actually look at integrating nurse call duress, fire panels, security code black buttons, mobile duress buttons, emergency messaging, all of that into a single application, or also looking at integration from clinical systems to also come into the same application to be able to be viewed on that. Since I look after the non-clinical side of things, our biggest concern was to make sure that what we sell to the client is what we actually can provide. So we did a lot of testing, especially with Imprivata lock screen, with Saudi as our MDM. We had to actually look at a lot of things, such as simple things that you would take for granted, such as a pop-up menu on the screen that says you have a code alarm in your ward. How do you actually push that out? You have to actually make sure that you test that correctly with your MDM platform to make sure that it actually allows you to push notifications out, to make sure that your lock screen, such as Imprivata, actually allows that to be actually displayed on the top so that you can actually tap on it and actually takes you in. So those are the workflows that we actually wrote up as test cases and provided to the testing team. So we did a lot of work with the testing team to actually integrate all these systems and actually test that. Couple of things that come sideways when we selected a solution that we were going to use for VoIP. We ended up going, well, this person, we had to make exceptions as we tested this, gave it out to the clinicians, and they came back and said, hey, this is nice, but could we do this as well? So there was a lot of that going back and forth when we were doing integration testing, especially things like certain staff members saying, this is going to be the fixed phone for the role. Can we actually get direct calls to it? So then we had to make sure that we tested that with a 4G device. And then when you select a 4G device, you have to make sure that there's 4G coverage. So we have the necessary equipment within the hospital to do full Wi-Fi scans of the 2 and 4G networks, Bluetooth scans, and also we're currently procuring equipment to actually do surveys on the mobile network as well, to actually run through areas and talk to clinicians and say, where would you like these? And if you have a spot where we have to actually take that into as what I'm trying to say is we need to look at not just the integrations on that end, but we also need to look at the infrastructure, because we have to consider 4G and Wi-Fi devices as well, and make sure we cater for that. Make sure the little things such as an application that actually picks up a reference ID from a SIM card rather than the actual device ID. We ran into one of those. So we actually had to do a lot of integration testing with that. And obviously when you do it on one device, it fails and you have to actually test it with a different device. So we actually ran into issues with one of our applications on a full Wi-Fi device with Imprivata, because when we were testing, Imprivata would wipe out the settings on the device to lock the person out, and that would wipe the device ID. And we had to get around it with the special version. So we did quite a lot of testing, extensive testing. Our wards persons were one of the first to receive the handset, and they did a lot of testing with us, and they used a lot of our apps as well. So yes, extensive testing, especially with your MDM and your lock screen. I can't stress that enough.
Yeah, and interesting about what you raised there, the fact that you've got the device, you've got the MDM, and then on top of that, you've got the single sign-on Imprivata, and you've got to make sure all three are playing together nicely to achieve those use cases. And talking about MDMs, Adrian, your title says CNIO, but I think after the last 2 years, we can now add MDM expert on there. And I remember in your case when we did the trial at Koala for the 13 devices, we did so without the MDM, and we had some interesting experiences there. But coincidentally, all three hospitals here are running the same SOTI MDM platform. But Adrian, just talk us through around what considerations you made on the MDM, especially I guess around how you came up with the kiosk with the lock screen, and why you chose to do that as opposed to keeping the device open.
We just Thanks, Alan. When we first rolled our devices out, I guess we made an assumption that everyone would treat their phones respectfully and would all have the same understanding of how phones work. But we quickly realised that if you're an Android user, no problem. If you're an Apple user, you can have significant problems. And even though there's only subtle differences between the interface, it soon became pretty apparent that we needed to lock the screens down. So that really became the driver for having a profile or profiles specific to the department that you were working in. And we gave a bit of a broad brushstroke because, again, it was all a little bit new to us. So we wanted to give both nurses, doctors, allied health, support services, a range of options, and then what we're currently doing now is refining that range of options to come up with a limited number of profiles, because not all use case scenarios are the same and not everyone wants to see all of the apps on their phone. So we're currently going through now to refine those down, and hopefully we'll end up with probably only 4 or 5 profiles that we need to go across allied health, medicine, nursing, and support services, where predominantly all of those devices are going. SOTI gave us the ability to do that, so we can have multiple profiles. We can push out different rules to send the different apps that we need for that particular profile, and managing that across a large number of devices, it really makes it pretty easy. Once you've worked out your profile, you've worked out the code for the profile, then it's just a matter of pushing it out, and it applies that new profile instantaneously. We did even come up with what we call a downtime profile. So when we went live, we bought the devices that had SIM card availability, and the purpose of that was really to give us the ability to access certain clinical applications if in the event of a downtime, if the network was to go down. And now I think the principle of that was the right way to go. I think the ongoing cost of that, we're probably a little bit naive in how much that was going to cost to maintain it ongoing. So our service provider was, we had trouble getting a shared data pool, so it was going to make it sort of prohibitively expensive over a 12-month period to have the SIM cards being used for redundancy if the network goes down. You know, it could have been anywhere between $70,000 to $80,000 a year just to have this sitting in the background. So we've since pulled back on that, and until we can get a reasonably priced data plan, we'll only use the SIM cards in certain phones across the hospital that are essential for communication. But all in all, the MDM has made life very, very easy. It gives us the ability and the flexibility to change things at a whim, and we can also accommodate the different profiles that are required across a hospital, given that not all users need the same applications on their device. It would be nice to think that it was very homogeneous, but it's not. Everyone needs something slightly different.
Thanks, Adrian. Yeah, and interesting what you're saying there with regards to trying to get all of the devices on a redundant data plan. Maybe offline, you can have some discussions with Patrick there, because I know they're using 4G quite heavily across ACT Health. Neil, so MDM considerations from your side, were you utilizing the SOTI MDM prior to rolling out the 85 versities you have there at Women's, and you know, what considerations did you make?
Yeah, so we were utilizing the MDM prior to the SpectraLinks, but we found that the integration between the two is seamless. We had a lot of assistance from Wavelink in setting up the SOTI MDM and all the profiles. When we first deployed the SpectraLinks, we also did the lockdown screen, and we probably don't use the the SpectraLinks to their full capacity. There's a lot of integrations that they can do. We primarily just use it for that EMR application at the moment, but are looking to expand. We locked the SpectraLinks down initially to 5 different applications, which the staff would use. They're all clinical areas where they're using them, and they'll use the SpectraLinks for the same purpose. So, and we actually haven't had any requests to expand that outside that use. So that's been great. As I said earlier, we're trialing the voice component as well, and look to hopefully start rolling that out next year. Yeah, it's been great, as Adrian mentioned, pushing out different profiles, using in combination with the SAM server to push out updates to the devices. When we have an update to our EMR platform or that EMR app, we push it out. It's pushed out to 83 devices that we've got running at the moment, and it approximately takes about 5 minutes to push that out, and we're done. And it's been great. You can do an upgrade, or you can completely wipe the application away and rebuild from scratch as well. So once it's on the MDM, it's pretty much you can do everything remotely. You don't need to touch the device.
Yeah, and that's important. You know, when I'm out visiting hospitals, a lot of people ask me around the security of the devices and how they can make sure they secure the data. And, you know, they're especially concerned about the device being useless if someone removes it from the four walls of the hospital. And, you know, with the geofencing abilities there in SOTI, I think that for me, that's been one of the key supporting features that I've been able to demonstrate. How when the device is off-site, you know, it can be essentially bricked so that, you know, no one can access the device or repurpose it for something else. Really, that's what moves me on to the next topic area, talking about implementation and post-implementation. Adrian, you've probably got, I think, more devices deployed at one single site than any of the other panelists on this call. And, you know, can you talk to me about, you know, the cutover process? How do you take staff members from one day using all those disparate devices to the next day introducing a smart device? I mean, surely there's got to be a lot of training and preparation to manage that cutover process and introducing those devices ward by ward.
Yeah, so we're about to do a medical imaging rollout of about 20 devices. Just going back, you know, we've done a sort of iterative approach across the hospital. Due to network considerations, you know, we didn't want to overload the network. We wanted to understand what was happening. So we generally do department by department, given that, as I mentioned, each department has specific requirements for their profile. So we want to make sure we get that right. But for medical imaging, what we'll be doing is I've got a training session with them on Wednesday. It'll only be about 30 minutes for that training session. Given that the phones are locked down and that we've worked with them to get the exact profile that they want for the applications that they use, we will give them assistance in working through some of the clinical applications that they might use, so the Rover and Haiku. And then we've got the phone access, and then those that need to receive notifications, we'll just work through them getting the notifications on the app on the phone. So previously we have pushed our paging messages to what we previously had were ASCOM devices, and now we've pretty well just used exactly the same number that they used on their ASCOM devices or their extension. So there's been no need for a directory change. We've mapped all of the paging that goes to that ASCOM device, and then we've made sure that goes to the SpectraLink device. So it should be a pretty smooth transition, other than just the basic functions of the phone. And again, it's Android versus Apple. Often that's where the problems might exist. So where are the buttons, which ones do you press, and when do you press them? So just really getting used to that. And they're mainly usability issues, and more that's what we're seeing is just usability issues rather than device issues. And that's a relatively easy thing to fix, and it just takes people time to get used to it. One thing I might mention just while I'm on this, Alan, and it's been interesting as a result of the pandemic where everyone's now wearing face masks. One of the issues that we have had with the devices is the lint from the face masks and the humidity from the breathing out on the face mask when people are talking. We do get in the microphone on the devices build up of lint and residue in the microphone, and a common call that we will get is people can't hear me when I'm speaking to them on my SpectraLink phone. So directly as a result of the pandemic, and this is really an unintended consequence of everyone now wearing masks, we've got a bit of a cleaning process in place. So that'll be one of the things that I'll be going through with the medical imaging department, just to make sure that the maintenance of the phone is really the responsibility of the person handing over that phone. And if for whatever reason you can't hear or people can't hear you, the likely impact of that is that the microphone needs a little bit of the lint that gets caught in the microphone, and we'll be issuing very soft toothbrushes to all departments, just to make sure that they do appropriate cleaning of the devices, because that's one thing that should not be overlooked, particularly in a pandemic and in clinical environments. And we want to make sure people, use the devices and are able to use the devices, unimpeded.
Yeah, but very unique use case there, and I remember walking across your hospital and seeing the toothbrushes being rolled out, and was thinking you're on a dental hygiene initiative until you informed me that was part of the cleaning technique for the devices. So glad that managed to solve that issue.
Yeah. Yeah, and something simple and really unintended. When we first went down the lines of the devices, no one would have ever thought that would have become a problem. But anyway, we have a simple way of fixing that. But it's a lesson for new players, given that masks are likely to be around for a long period of time.
Yes, exactly. Pat, user acceptance. How's the reaction being from the end users? Is your experience like Adrian's? Are most of the people, Apple users that are pressing the wrong buttons, and in generally, how are you finding that the end users have adapted to the technology?
Yeah. So our latest one of our latest deployments was at the AI's Mass Vaccination Center at Canberra, where we rolled out the devices. I think in a few days. I think the entire site went up really quickly. So we had to push out Duress and Epic Rover on that app on the phone, along with the ability to make phone calls through our Cisco web system. So the user acceptance was actually quite good. Most staff on the floor were Android users, luckily for us, and the Apple users didn't have too many issues with the phone. The most common thing for us was with the position of the buttons, and so we just made sure that we had a cheat sheet at every charging dock, just to show that here are the buttons, this is how you turn the phone on, this is what you do, unlock the phone. Something simple to get them into the application. We just used Sodi to do a single single application mode, which basically launched them straight into Epic, and they could just log in immediately to their application and go on about their day's work. It got a little, it took maybe a day or two to get used to. Most staff were quite keen to see the new devices, so they were happy to actually use them. They understood where the barcode buttons were within the first day, because they were so busy that they got used to it very quickly. Another implementation we had was in the mental health ward that we just recently did the mobile duress solution in. We knew that they were coming in from a wireless Wi-Fi based mobile duress solution, which was different handset altogether. So we knew that they would have, it would be similar, but not the same. So what we did was we, I think, had about 4 or 5 sessions, basically before the rollout of the handsets into the ward, before the staff actually started working in the ward, to just get them used to the handset and put the system in test, and then told them to play with the handset. It's one of the best ways that we found that the staff interact, and they go, okay, I have free reign to use the phone. Let me do everything I can to break it or use it to raise alarms to see what exactly happens. It gives them a lot of confidence when you do these sorts of hands-on things and you put the system in test and give it to them. They are very open to the phone. They loved it, and we have, I think, had only 1 call in the ward, and that was to, I think it was just a simple thing of restarting the phone, and that was it. We've never had a single issue with the phones in the ward. So staff are very happy to, I guess, what we've noticed is that staff are very happy to onboard a phone when you give it to them with some hands-on time to play with before they actually go into the live environment. As for the Epic side, it was just so, they got so used to it that they started calling the phones rovers instead of clinical work devices, which got a little confusing at the start because we were looking for rovers and we didn't understand. We thought they were computers on wheels of some sort, till they actually explained that none of the clinical work devices are rovers. So we had to do a little bit of a re-education there just to tell them that there are more functions on this phone. So it's a clinical work device, not a rover. But they love it so much that they, I think, most staff do not use the computers there. They actually prefer to use the clinical work device with the Epic rover on it to do all their daily work at the vaccination center. So it's been very good so far.
Yeah, I've heard wonderful things about that mobile application, and that people prefer the interface on the mobile app to actually the desktop interface, which obviously works very well for us, being the providers of the mobile device. And I guess, really the user experience, a lot of that comes down to user training. Neil, when you rolled out your devices, did you conduct any specific user training? If so, was that done on a train-the-trainer, or was it ward by ward? How did you handle that prior to the rollout?
Yeah, so we had some issues at the start, and that was mainly because of the previous devices that we'd rolled out. There was a lot of uncertainty about using the devices because the previous devices were dropping off the wireless network and they weren't reliable. So we almost had to get the users or give them a bit more faith in the SpectraLinks. And that has grown over time. They've seen that they're a lot more reliable when using the Epic Rover application on them. One big thing that I'll mention about the AMI Analytics software is we're trialing that, and we're mainly trying to work out where these devices are being used and where they're not. We do have some departments that have got the devices, but they're just sitting in the charger. And we've been able to identify that by using that application, and then go and ask them, is it because you're not comfortable with the device, or is it lack of training? So that's been really useful by our EMR team to identify this, and potentially they don't have a use for it, so we can reallocate those devices to departments that have a greater use for them. So that's been really important for us.
Thanks for that. And yeah, interesting use case for AMI Advanced there around, device utilization. And, even things I remember, Adrian, when we showed you, we could show things like barcode scanner uses. So if you've got mixed fleets of devices, some with barcodes, some without, you can see how many times the barcodes have been used on the device each day, and know whether you need to reallocate devices. If I could ask you, Adrian, in terms of ongoing user support, how is that currently handled through the hospital? So, if post go live, someone does have an issue with a CWD, what's the process that they go through to report issues?
So we have, well, in fact, across the precinct, we have a centralised system for reporting back through our help desk. Up until now, we're just transitioning to our help desk now, but up until now, it's mainly been the EMR team and some of my nursing colleagues that have helped troubleshoot the device. I've mainly managed the back end with some assistance with from Wavelink, and Fook at Wavelink has been terrific, and Alan as well. So the aim is to transition, I guess, usability issues to the normal IT help desk. They've all had their training now, they've got a tip sheet, and you know, they've already started taking that on board and solving problems and getting in contact with us should they not be able to solve a problem. The back-end issues such as AMI monitoring, SAM server configuration, all of that will be handed over to the network guys, and I've got a training session with them on Wednesday, and they'll be able to make extensive use of the AMI advanced monitoring, and they'll be able to do the configuration of the SAM server and also the use of SOTI. One of the things that sort of runs hand in hand is the use of Cisco Call Manager when you have when you're using voice on the devices. Now, I haven't been trained in Call Manager. I don't have access to Call Manager. I think ideally you need a team that have experience across all those three applications because they're so intertwined. If you have a problem with the device, it's going to be either Wi-Fi related or call related, and someone that's providing support needs to be able to pinpoint and target the issues straight away and get them resolved as soon as possible. The one thing that we have noticed with nearly 811 devices on the network now is that these are essential pieces of the toolkit for clinicians and in fact all people across the hospital now. They have to be able to document, they have to be able to communicate, and they've got to be able to raise duress. So no longer can we afford to not have devices fixed, and you know, we've got a pretty good record on the EMR team at making sure that the end user gets their device back up and running as quickly as possible. And if we can't fix it, we swap that device out straight away. This is essential. It's an essential utility on their tool belt, and it needs to be a high priority for all clinical staff across the hospital.
Thanks, Adrian. And yeah, you really sort of highlight there that it's a lot more than obviously we're providing a device that's fit for purpose, but we're also providing the tools and then the support in terms of, you know, the troubleshooting and even down to hardware replacement of devices. I guess where I'd like to, sorry.
I was just going to say that, you know, even with our own personal phones in our day-to-day life, we all find that we'd like to do without them, but we can't do without them. And I think there's similar anxiety in the health system that we've essentially made people dependent upon these devices for communication, for documentation. It's an essential piece now, and what you don't want is people don't cope very well if they don't have the tools of the trade to function. So speedy resolution to issues is a priority. Thanks,
Adrian. What I want to do is now just finish up with a final question, which I'd like to get an answer from on everyone, and it's really around key learnings that we have on this call. Potential customers. We have people that, you know, within the next year or two will be figuring out what their own smart device strategies are for their hospital. And, you know, certainly some of them will be looking at, do I need a purpose-built device? You know, a common question I get asked is, why don't I just go out and, you know, spend a couple of $100 on a Samsung phone? They're cheap enough to replace them. If I could ask you guys to sort of give comment on that, you know, what are your key learnings, and, you know, why should a customer look towards a purpose-built device as opposed to trying to take a consumer device and bring it into the enterprise healthcare space? And I'll go around a circle sort of asking that. So Neil, if I could start with yourself on that one.
I think you touched on it before when you said a tool belt. Really, what we want for our clinical staff is we actually want to get away from the tool belt and just have one device. And you really want one device that you can integrate all the different things that that clinician needs to use. So phone, you know, the applications that they want to use as well on it, barcode scanning, paging, Improvata, all of those sort of applications, you can put it all in the one device, and that's what I would say. This device, you can integrate all of them and just have one single device, which meets infection control. It works well on the wireless network. It's mobile. It's easy to use. You can configure it using the appropriate MDM with profiles. It's easy to upgrade. You don't need to touch the device to do all of those things, and that's what I would say. Just a single device is the key.
Thanks, Neil. And Adrian, same question to yourself.
I think that, the advantage of a single device is the uniformity, and if we gave everyone a choice about the device that they would like, they would all go off and buy whatever suited them. But to be able to manage that in an organisation is going to be extremely difficult in terms of the support that you have to provide. The other thing I think that is worthwhile noting is that we've tried to see these devices as role-based rather than person-based. So sure, if everyone's going to get their own device and and it's personal preference, but we see the hospital as using roles. So we've got a after hours specialty registrar, we've got a associate unit manager as a nurse, we've got a endocrinology resident. So we see it as roles, and that the people are the ones that are passing through the organisation, filling those roles. And reinforcing what Neil said about the flexibility of the platforms that we're using, the flexibility of the devices, people are transitioning through their work life as a role rather than an individual, and I think that's how we're trying to treat the devices. They have an individual login within the clinical systems, but the devices and the systems that they're using, in order to make it cheaper for hospitals, easier to manage, and cost effective. Just on a point there, and we talked about the tool belt that we used to carry. We've gone from 3,800 devices across the hospital, and we will get in under 1,000 devices for people to have a single device. So, if you put aside for Sarah's, pages, phones, all manner of devices that they'll have in their toolkit, and now we've been able to roll them all into, under 1,000 devices for an organisation. I think there's a very good economic argument to moving to a single device, such as the SpectraLinks.
Thanks, Adrian. Appreciate that. Patrick, to yourself.
Yeah, from our perspective, the way I look at it is more around durability in a hospital environment. So you can obviously buy something like a Samsung that's an A51 or something like that that's cheap, and use it, as Adrian mentioned. If it's a personal phone that's going to be locked to a person and that person is responsible for that phone, then the onus is on that person. But when we have the phones, the way we've implemented them as role-based devices, you need to ensure that a single phone can travel through the entire hospital without having issues. So whether it's a phone for a wardie who would be required to do a lot of work around the hospital, they could get their phone damaged, crack screens, those kinds of things could be dropped on the floor. Or if it goes to the nurse and it's in a ward, obviously the most common thing is getting dropped on the floor. You want something that's actually rugged and runs the latest operating systems to keep up with the latest applications, because you need to ensure that you have a single device that can actually facilitate a multitude of functionalities. So we went to look for a device that is robust, which was the biggest sell point for us. Obviously, the phones that we have are very, very robust and drop tested by us even in the office every now and then, just to show new staff that they can be dropped and they still work. And obviously they have run the latest operating system, and they bring out security patches in line with Google's security patches. So that's another thing. Obviously, if you have certain vendors, it really depends on their support for the device. If it ends at a certain point, you're not going to get any support for it. You need to ensure that you get a manufacturer who will actually provide you with ongoing Google security updates for your Android, or if it's an iOS device, well, iOS doesn't really matter at this point, but most people have Android devices. So you want to make sure that those happen, which we get with the SpectraLinks on a 3 monthly basis on par with Google's releases. So it's actually quite good for us. So from my perspective, because we do manage the hardware component of it, durability is a huge part, and obviously something that can be used in a hospital environment that can be rubbed clean with alcohol and so on. So cleaning liquids. So that's a big sell for us.
Thanks, Patrick. Really good note to finish on there. Just want to reach out to our guest if anyone's got any questions. I've got one here. Okay, someone's asking, I have a customer who would like to review the recording he missed. How can he access this? If you reach out to us at Connected Health by my email, alan.stocker@connected-health.com.au, then I'll be happy to share a copy of the recording. Got a question that's come in here. Has there been any adoption challenges with medical staff, given that they're used to BYOD strategy? Adrian, perhaps feed that one to yourself, as you're quite in touch there with the medical staff at the facility.
Yeah, so again, everyone I think understands that most of the medical staff. So we've pretty well configured our devices for junior medical staff roles that move through the hospital. They may be on rotation, it may be part of their training. They move into a role and they pick up that phone, and that becomes their phone for that role. There's two categories. You've got the senior medical staff, and the senior medical staff pretty well have their own BYOD device and use that as they will. And again, they can easily go and load any of the apps, so the Rover app, the Haiku app, all of them manage that. We've got two-factor authentication on all BYOD devices, so they pretty well manage that themselves and can be contacted via switch through their mobile phones. So it's less of an issue for them. I think ongoing it may become more topical if the hospital decides to go down to individual-based devices for BYOD, but it's a very tricky topic when you say to someone that we want to be able to control aspects of your either hospital own device or your personal device to be able to control from a security point of view. I think most people that carry their own device, I carry my own device and never have any problems with it. I run all of my own applications, and I think people become familiar with it, and I don't expect the hospital to be able to have to help me troubleshoot it. So I think keeping it separate, I think, is important. If you have a role at the hospital and you move through that role, then I think providing a hospital issued device is the right way, and I think BYOD devices should be exactly that. They're my device, I manage it, and I'm responsible for it. Hopefully that answers the question.
Okay, thanks for that. And Patrick, another question that's coming in here is with the use of 4G on the devices, are you utilising them for call failover in the event that the phone cannot access the Wi-Fi network?
So our hospital has actually got a very good wireless system, but obviously we do have older parts of the hospital that don't have ample Wi-Fi coverage. Our wardies and our equipment services staff actually go through all these areas, including security, some security guards who also carry these phones. So the phones actually the 4G phones actually come with VPN installed on them to actually allow them to route back into the hospital network. So we use our 4G devices primarily as a way to bridge the gap where we have no wireless coverage, black spots, lifts, for example. We're working on getting wireless in the lifts, but until then we have 4G devices for these specific roles so that they can actually continue to use the functionalities on the phone without any disturbances. So that's our primary reasoning for the 4G devices. There was another reasoning with the application that actually required a 4G device, but outside of that, our primary use case for 4G devices is purely for the to bridge the gap between the wireless network to get the devices back on the hospital network so they can access applications on them.
Thanks, Patrick. And another question for you. You're popular today, but can you talk about using Improvata? Someone's asking, what's the solution does it provide you? And what have you found the advantages of using SSO versus not using SSO on the mobile devices?
So Improvata is heavily used in our hospital. All our computers on wheels have them to tap on and off for the clinical staff, so they're actually quite used to it. So having that as the default solution for the clinical work device was a no-brainer for us, especially since they provided us with an application that did that. Implementing it was quite simple. Obviously, you put it in, the Improvata team just organized the individual application access, and single sign-on just took care of the rest. Since most applications were AD authenticated anyway, it became very easy to just get them in, logged in very quickly. I myself have actually tried out a few of the clinical applications that they've given me, obviously certain test access to, and it's actually very smooth. You tap on with the application, tap on with Improvata, it lets you into the phone. Saudi locks the phone down to a single screen. You select the applications that you want to launch, and Improvata automatically puts the details in there. And if there is a custom application that requires password changes that are not linked to AD, Improvata allows you to go in and change the password for that at any time. So it's been quite good. Single sign-on, I would say, is the best way to go forward with. Without it, it is quite clunky. Obviously, you'd have to get your keyboard out and start typing things. But if you could just tap on and just load an application automatically, and it logs you in with your user account, it is just amazing. So it's been very good.
Okay, and we are slightly going over time, so I've got time to ask one final question. But and this is an open question to everyone, but has any teams within your facilities done any research to the efficiency improvement by being able to do everything at the bedside, as opposed to having to go back to a computer? So feel free to pitch in.
Happy to answer that one, Alan. Just as an example, so we as people probably know, we have an Epic EMR and we have the Rover application for nurses. And within the Rover application for nurses, we get monthly reports generated from the EMR that give us an indication of what components of the Rover application that people are using. And we've got, I was looking at a slide the other day just on the data from the time that we first implemented the Rover application to current date, and we've had a reduction in the amount of time that people are spending documenting in the EMR. So they're far more efficient by having a mobile device, and the time taken to do that documentation has reduced since we've pushed. Well, in fact, all nurses on the floor have a SpectraLink device or a Rover device, as Patrick called them. We call them that too. But people are becoming much more efficient in terms of their documentation by moving to mobility. And in fact, in our hospital in the home setting, we've configured their what they call flow sheet rows that they would normally document on a computer. We've configured those within the Rover application with a view to hospital in the home where possible, only taking out a single device, which is the SpectraLink, to do all of their documentation, their navigation, their medication administration and their communication. So that's the vision that we have for that, and we've started that. It's some people are using it, and we just need to get out there and support those people a little bit more as they transition to the single device for all of their work.
Cool. On that note, I just want to, Neil, Patrick, Adrian, want to thank you so much for attending today's session. Really interesting discussion. With all the questions we've received, I can see that the attendees have found it interesting as well. So, as I said at the beginning, stay safe, everyone. Stay well. I look forward to catching up with all of you before Christmas. And yeah, thank you very much. Really good session, guys. Appreciate it.
Thank you for having us.
Thank you.